Okay, once again, for those of you just joining us, my name is Leanne Foster, and I am a Provider Outreach and Education Specialist here at WPS. I'd like to welcome everybody, and I hope you are doing well. Today, we are going to be going through E&M services, E&M home services. This is the first in a two-part series that is specific to home services. Today, we're going to give you the policy guidelines, we're going to give you the billing guidelines, we're going to give you that structure, that overview. Tomorrow, Ashley is going to be holding an interactive session that is a Q&A session. We will be asking you to actively participate in that session through some question and answer sessions and some quizzes, just to help you apply your knowledge. So today, you'll be gaining that knowledge, and tomorrow we'll do a review. She's also going to talk about denials and rejections and how to correct those, again, along with that interactive session that will help you apply your knowledge from today. So what's the goal for today? As I said, we're giving you that overview. We want to provide you with a better understanding of E&M services that are performed in a patient's home. To do this, we're going to talk about a couple of things. First, we're going to talk about Medicare's requirements for home services, including how the home service codes that are used to deliver these services. We are going to talk a little bit about telehealth as it relates to home services. And then we're also going to talk about incident to services. Finally, we will be covering some prolonged care service codes because home services are eligible for that prolonged care. We're also going to talk about the billing requirements for that. We'll talk a little bit about Homebound. We're also going to talk about place of service. And then finally, to wrap things up, we will talk about documentation and give you some tips that will help you with documenting home services. As with pretty much everything Medicare, we are going to be using some acronyms today. It's not even Medicare, it's our entire lives, right? So we are going to be using some acronyms. I'm not going to run through these, but I have included a list of the acronyms that I will be using today so that you have them for reference should you need those. I'm going to start with some basics about Medicare home services. So today, it is important for me to point out that we are focusing on E&M services that are provided in a home or residence. This is not an alternative to home health benefits provided by a home health agency. I want to just be very clear about that. This is going to be a smaller subset of codes, and it is separate from that home health agency benefit. We're talking about E&M. We're also not talking about your typical home health services, or excuse me, telehealth services. We will talk a little bit about home health delivered through telehealth, but again, telehealth services as a whole is not the focus for today. We do have some webinar recordings. Actually, Barry Muko, one of our colleagues, just did a session on that is telehealth, past, present, and future, that you may find useful, and that's actually on our Encore presentations page now. And I point this out because we did get a pre-submitted question asking how long CMS is going to allow for home services. CMS has not made any indication that home services or E&M services provided in a patient's home or residence are going away. What I believe the question may have been asking, and if there's more context to that question, if the individual is on the session today, please let me know that in chat. But telehealth, I know there have been flexibility extensions and they were allowed to expire on September 30th. And we'll talk about that just a little bit. But telehealth nor home care services are something that's necessarily going away, but with telehealth, there are some changes with those flexibilities expiring. So back to our home health services overview, I want to start with who can provide these services. So home health services can be provided by anyone who's eligible to bill for E&M services. Remember, we're talking about E&M home health services. So this is going to include your physicians. So this is your MDs and your DOs, your non-physician practitioners, so nurse practitioners, physician assistants, clinical nurse midwives, things of that nature. And it's not, these services are not restricted by specialty. So it's not just a subset of that 2-digit specialty code that providers select during the enrollment process. It's not restricted by that. Home services can also be provided incident 2, and we're going to talk about that more later on today. But this means that there's going to be times where home services can be provided by your clinical staff. But again, this is only for incident 2 service guidelines, and we will be talking about that as well as definition for homebound later on. Sorry, that just moved on me. So next we need to look at the patient status. So what I mean by patient status is the patient new or established to you or your practice? And this is no different than with office E&M services, but it's important to make sure that you know the difference because established patients do use a different set of procedure codes than the new patients. And we'll talk about that a little bit later on in the session as well when we get to billing. I want to start with the definition of new. So in the context of Medicare, a new patient is defined as a patient who has not received any professional services, so office visits, consultations, what have you, from the billing provider or another provider in the same group practice within the past 3 years. So let's break that down just a little bit. Same provider, pretty straightforward. This is, for instance, the practitioner is Dr. Smith. The same provider here would be when they've seen Dr. Smith within the previous 3 years. Maybe they saw them in the office, but they are now seeing them in their home. And maybe they're seeing them in their home because it's more convenient for the patient. Maybe it's just how the provider provides their services. But if they've seen them in the previous 3 years, they're not going to be a new patient. And this same provider concept is driven by MPI, not tax ID. A question that we do get pretty often is, what if my provider, went to another group, so now they're under a different tax ID, and now they're seeing that same patient? The question is, does that make them a new patient because it's the same provider, but they're under a new group? That's why I point out that it's driven by MPI, not tax ID. So the answer to that question is no. Because the same provider is seeing the same patient, so in the example that I gave, Dr. Smith saw the patient at ABC clinic. They're now seeing the same patient at XYZ clinic. It's still Dr. Smith seeing the patient within the past 3 years. So that is still the same provider. So just keep that in mind. That comes up quite often. I also want to point out that if you saw a patient in the office or inpatient care, they might have been new there. When they get to a home visit, that would be subsequent. And we'll talk about that a little bit more. So same group, that's driven by tax ID, not MPI. It's going to be driven by that federal tax ID that group, that clinic is set up under. This means that if you have 2 providers under the same tax ID, they are in the same group. Same specialty is again going to be that 2-digit specialty code that is selected during the enrollment process. And so examples, a cardiologist and a family practice are different specialties. They could be under the same tax ID, but they are different specialties. I also want to point out that an MD and DO and a non-physician practitioner are different specialties. This is driven off of that 2-digit code for the specialty the provider selected during enrollment. I do want to point out that's not based on taxonomy. It is based on that 2-digit specialty code. So again, that subsequent visit is going to be a patient that has been seen in the previous 3 years. Maybe you haven't seen them for 2, but if you've seen them in those previous 3 years, and it's same physician, it's same group, same specialty, they're going to end up, having a subsequent visit. I also want to call out that, and we get this question as well, is what if the patient is changing their place of service? Maybe they were inpatient. I mentioned that before. They're inpatient, now they're receiving home visits. That change in place of service or that change in that status does not start a new patient visit. That new patient visit is based on that provider. So we often get questions on whether a patient needs to be homebound to perform services in their home. Now remember, as I said earlier, this is different than a home health visit or benefit that is rendered by a home health agency. So the answer to that is no. Now there are certainly going to be situations for incident 2 where homebound plays a part. So we will talk about that in a few minutes and talk about the CMS definition of homebound. But typically patients do not have to be homebound to provide an E&M service in the home. These are, again, E&M services that are being provided in the home for a variety of reasons. It could be patient convenience. It could be the way that practitioner provides their services. There's a number of reasons why a patient might receive these services, but again, it is different than that home health benefit. I do, as a reminder, we get this question as well about RHCs and FQHCs. Practitioners providing services as part of those two organizations, again, those RHCs and FQHCs, they can and are eligible to provide services and bill for services provided to patients in their home. So they can utilize these codes and bill. So because Incident 2 is going to have a homebound component. There's going to be times where that homebound status does impact it. Before we get into the billing pieces, I do want to make sure that I talk about the definition of homebound. Homebound does not necessarily mean that a patient is staying in their home 24 hours a day, 7 days a week. It's actually a set of criteria that the beneficiary has to meet or the patient has to meet. So it's not just as simple as their home. CMS does define the criteria for homebound in the Medicare Benefit Policy Manual, and it's in Chapter 15, Section 60.4.1. We're going to talk about it, but this is a good reference. In fact, let's go out there. Give me 1 second. And as I said, it is 60.4.1. So here you'll see the section in that Medicare Benefit Policy Manual that defines homebound. As I said, we are going to go through it, but this is out there for you so that you have that. So there's 2 criteria, and both have to be met. It's not one or the other. They do need to meet both. Sorry, I did not want that to shift. I apologize. But they do need to meet both. It's not one or the other. And it's required for billing of clinical staff services, which is why it's for Incident 2, because typically Incident 2 is going to be those clinical services. So it's going to be something where your documentation is going to have to support that. Now, typically absences from the home for homebound patients are going to be infrequent and for short periods of time. So that's something that you have to keep in mind. But again, those criteria that have to be met. Criteria 1, CMS outlines that if the patient does in fact leave the home, the patient may nevertheless be considered homebound if they need the aid of supportive devices. So those supportive devices include things like crutches, canes, wheelchairs, walkers, or maybe they need a special transport vehicle, maybe it's a special van with a lift, what have you, but they're needing the assistance of another person to leave their place of residence. So it's where they're not able to leave without that additional support of either a device or another person. So it also could be that they may have a condition where leaving home is contraindicated. Now, an example of that is going to be, say you have a patient that has an extremely compromised immune system. They might be perfectly mobile, but their immune system is so compromised, they cannot be around other people. It could also be that perhaps they have a condition that's extremely contagious and they need to limit their exposure to people. We went through that with the COVID-19 pandemic where there were those concerns. So those are just examples. The providers can document what condition they have where leaving the home is medically contraindicated, but it does have to support why leaving the home is contraindicated, and it needs to be clear to a reviewer. So that's criteria 1. Criteria 2, it expands on criteria 1 just a little bit. So there must exist a normal inability to leave home, and leaving home must require a considerable taxing effort. So people will ask what this means. So you may have a patient that is in a wheelchair, right? But let's say they're in a motorized wheelchair and they're using a special vehicle to get, say, to the grocery store, go to church, going to doctor's appointments, going to visit people, but they get around. They do meet criteria 1 because they do have a supportive device. I threw out in the example that they maybe have a special vehicle, but they don't have an abnormal inability to leave home. Those motorized wheelchairs in this example go everywhere. And if they're able to manage that and they're able to leave by themselves and they don't have that medical condition that makes leaving the home contraindicated, and it's not taking a considerable taxing effort to do so, they don't meet the criteria for homebound. Again, if they're pretty independent, they're not meeting that. So that considerable taxing effort does need to be documented. It needs to show the patient's normal inability to leave home and why it's a considerable taxing effort. Those are things to keep in mind. And as I said, homebound patients may leave their homes occasionally. Maybe they're visiting relatives, maybe there's an event, maybe it's a doctor's visit that can't happen any other way, but they do need to meet criteria 1 and 2 to be considered homebound. And again, this is for those services that are provided by your clinical staff. Now, one question that we do get is that, what if an aged person does not often travel from home because of feebleness or an insecurity brought on by advanced age? Does this qualify as homebound? This alone is not something that is considered confined to the home or homebound for the purpose of reimbursement. And this is because they're not meeting the above conditions or the criteria 1 and 2 here. So documentation needs to show how they're meeting criteria 1 and criteria 2. Preference is not enough to establish homebound status. I do also want to call out that because this is for Incident 2, this is something that is applicable if you're doing Incident 2 services by that clinical staff. If that practitioner is an MD, a DO, or a non-physician practitioner, an MPP, performing those services, homebound criteria is not going to apply. They don't have to be homebound for those services. So next we're going to look at billing requirements for homebound services, starting with the place of service. So there are certain place of service codes that are considered the patient's home. You see place of service 12, this is going to be the patient's private residence. It could be their house, their apartment, but it's their private residence. It's not a facility. It doesn't have any kind of medical component to it. You'll also see here that place of service 13, that is an assisted living facility, and it has a medical component, but they are living there, so that is something where E&Ms for home services could be applicable. You'll also see that we have a group home. So this is going to be some sort of a licensed intermediate care facility for individuals. It could be individuals with intellectual disabilities. You may also, with that, use nursing facility procedure codes. It just kind of depends on the situation and the patient. 33 is going to be a custodial care facility that does not have a medical component. And then 55 is a residential substance abuse treatment center. Those are the place of service codes that you would use. You'll notice that a nursing home and SNF, I mentioned them, or mentioned nursing home, but they're not listed. And I want to stress that is because they have that medical component and they're not considered the patient's home, even if the patient is domiciled there and they're not there with the intent to move them to their private residence or an assisted living facility. That has its own place of service. Those are different codes that are built, and so those are not part of home services. That nursing facility, that skilled nursing facility, will never be considered that patient's home. 12 and 13 are the ones that we will see the most often, but I wanted to make you aware of the other ones that would be eligible. Also, one other item that I want to call out from a provider enrollment perspective, we do get this question a lot, is that a private residence, so if you're looking at place of service 12, that is not something that would be listed as a practice location on a provider's enrollment record. However, all of the other locations that are listed would be, and that is because they are facilities. They may or may not have a medical component, but they are facilities and they are not considered a private residence for that patient. Here we have the codes that are used for home E&M services. There are codes for new and established patients. So you'll see the new patients are 99341 through 99345. There are multiple because of level of service. And then for subsequent patient, we have 99349 and 99350. You can select level of service for home E&M services using medical decision making or MDM or time. You just need to remember if you're using MDM, that is based on the patient's problem, the data used, and the risk to the patient of the plan of care or the services being provided. But your documentation does need to support the level of service. Remember, level of service or that MDM, that's your proof of thought. Your documentation is that proof of thought. And we need to be able to clearly identify the need for the level of service being built. If you'd like a little bit more information on choosing your level of service, I am going to ask Ashley, and she's placed that in the chat. Thank you, Ashley. Place a link to a recording of a webinar that we did earlier this year that does break down choosing your level of service. It goes into both MDM and time. So that is something, if you're looking for more information on level of service, you may want to check out. Also, I want to point out that time, make sure you are accounting for both face-to-face time with a patient and non-face-to-face time. There are qualifying activities that, things such as reviewing tests, maybe you're ordering tests post the session. You did the work and you want to get paid for that. So just make sure that you're accounting for everything that you did. So home services can be provided as telehealth. As I said in the beginning, we're not covering telehealth as a whole. We're going to talk about telehealth as it relates to home care services, but they can be delivered as telehealth. However, PHE flexibilities, many of them were not extended through December of 2025 through the end of this year, were allowed to expire on September 30th. So we're going to have to watch for any more information coming from CMS in 2026, but barring congressional action, the following items do apply. So for dates of service through 9/30 of 2025, the flexibilities regarding geographic restriction was in place. After October 1, the geographic location restriction is back in place. So that means that the patient is going to need to be in a rural area, and that's going to be that health professional shortage area or that metropolitan statistical area, that MSA. So rural and that geographic area is going to apply now. Also, the use of two-way interactive audio video technology is going to be required. The provider needs to be capable. If the patient cannot or chooses not to have the session via audio and video, they may not have the capability, they may choose not to, that is okay, but the provider needs to have the ability for that. You will want to make sure that that is documented for telehealth services. Again, if that comes up on review and we're not seeing that that telehealth service came through, and we're not seeing that telehealth service was that video audio, and we can't support why it was audio only, that is going to be something that's going to be questioned by a reviewer. And if it is delivered by place of telehealth, make sure you're using the right place of service. And if the patient's in their home, these are home care services, you're looking at that place of service 10. I did also include, CMS has recently issued, they issued it in October, but they issued an FAQ regarding what those flexibilities expiring means. I'm just going to take everyone out to that. So this is that FAQ. This is a really useful resource as far as what those expiring flexibilities means for the providers. We're essentially going back. Now, some flexibilities were made permanent or they're extended out through the end of this year. This does go through those more in depth. And again, there's that video that is available on our Encore page, which is telehealth services, past, present, and future, you may want to check out, and does talk about some of this. So next we're going to go into Incident to billing. I've been talking about this. This is going to be those services that are being provided incident to, following those incident to guidelines by those clinical staff. So these home services can be provided only in certain circumstances. So this is going to be, it's incident to, so it's someone other than the provider providing those services. So somebody other than the MD or DO or that MPP, whoever is that patient's provider. It's going to be one of their clinical staff. Incident to is that situation where the patient does need to meet the homebound criteria. Remember, there's criteria 1 and criteria 2. They have to meet those criteria, and that criteria needs to be documented. So if they are not homebound for a service, the billing practitioner must be present for that service. So in order to have those clinical staff do their incident to services, they do need to be homebound. The services that they do need to meet typical incident to guidelines. So this means that the service being provided to that patient needs to be part of the continued plan of care for this patient. That plan of care needs to be established by that physician or non-physician that's overseeing the patient's care. And what the clinical staff are doing does need to be laid out in that plan of care. For homebound patients, the supervision is going to be general supervision. So this means that the physician does not need to be present, but they are in charge of the services overall, and they're responsible if there needs to be some type of a change in that plan of care. They're available to step in if they need to, but the plan of care is not changed without the input of that physician. These services are also going to be billed through that provider, whether it's that MDDO or that nurse practitioner, but they're not being billed by the clinical staff. They're being billed by the provider. These services are incident to. And then also, as always, the services do need to be medically necessary, and that needs to be supported in that documentation as well. That last bullet I do want to call some attention to. Incident to is going to also be something that's available when the services cannot be furnished by a home health agency. And so your documentation is going to have to support that. Remember, there's that home health benefit, and these are not part of that. So if a home health agency is not providing it, your document needs to show that maybe there's not a home health agency in the area, or maybe that home health agency or HHA is telling you they cannot provide the service. Why can't they provide the service? Just make sure that that information is in there so we understand why this is not being performed by a home health agency as part of that home health benefit. And so obviously, along with that, this patient is not going to be under that home health agency care or receiving that home health benefit. This is not in addition to. One thing I do want to call out with Incident 2 as well is that Ashley and I did do a two-part series on Incident 2 services back in September. So if you're looking for a little bit more in-depth information on Incident 2, that may be something to check out. But I also want to highlight some services that can be provided by Incident 2. Now, I did include a link to the Medicare Benefit Policy Manual, and it's Chapter 15, Section 60.4, but it does call out the services that can be provided Incident 2, and this includes things like injections. Maybe they're getting some type of injection for a condition that they have. Maybe it's a flu shot, maybe it's a COVID shot, but injections. Venipuncture, it could be a dressing change after a procedure. It could also include teaching and training the patient to be an integral part of their care. So it could be the care of, say, a colostomy. It could be care of a permanent tracheotomy. It could be maybe there is foot care or certain testing that the patient is doing. That's typically for diabetic patients. It also could be things like blood pressure monitoring. Now, this is certainly not an all-inclusive list. That is available in Chapter 15. It gives a little bit more robust list, but that medical record documentation needs to show how these services are part of that patient's plan of care, and you're going to just want to make sure that you're showing that who is providing these services. So is it Nurse Jackie that's providing the services? And then what are they doing for the patient, and how is that medically necessary, and why is it being done at home? That's the type of information we're looking for. So prolonged care is something that will apply to home services. However, it is only available if you're choosing your level of service based on time. You cannot use MDM when choosing the level of service. Or the prolonged care, excuse me, MDM when wanting to bill for prolonged care. Choosing MDM or time, you will select the one that's most advantageous to you. Again, you did the work and you want to make sure that you're getting reimbursed for that work. We want you to be reimbursed for that work. But if you're using time, prolonged care is something that can be utilized. So the code that you're going to use here is going to be G0318, and it is used once you have exceeded the highest level for either the highest new patient or subsequent or established patient CPT code. So here we're talking about 99345 and 99350. It's also something that must meet the time thresholds that are set by CMS. Now here I have provided you with the chart, and it's showing that for 99345 you have to meet or exceed that 140 minutes, and then for the 99350 it's 110. Do you want to show you a couple of places that you can find that besides this presentation? One of those is going to be in the Evaluation and Management Services MLM booklet. I have provided a link to that for you in the training material for today. And there is a section on home and resident services, and it includes prolonged home care. So here's where they're talking about many of the things we talked about today with place of service, but here are the instructions for the prolonged care services. So this is something that you'll want to look at. The other is going to be and I'm a searcher, so I'm going to go ahead and I'm going to search for the code. Easiest way to get there. Oh, wrong one. My apologies. Sorry, thought I had that up. So we're going to go out to regulations and guidance, go into the manuals, and I'm going into internet only manuals, and I'm going into the claims processing manual. And chapter 12. It would help if I typed the right code. There we go. So here we are in the claims processing manual, chapter 12, and this is going to be section 30.6.15.3, and this is going to show that same chart but in manualized format and just has some additional information on that prolonged care. So that's there if you would like to check that out. Now, when you are using prolonged care, you want to make sure that you are counting all of your time. And with these, as you can see here in the chart, you can include time from the date of service, so the date that you saw the patient, but also you can include those non-face-to-face qualifying activities that occur up to 3 days before, so preparing for the visit in some way, or up to 7 days after. So make sure you're including that time. The other thing I want to call out is that prolonged care visits are billed in 15-minute increments, so you must meet or exceed 15 minutes to bill for prolonged care, and then you need to meet or exceed an additional 15 minutes for any additional units. So that is something that can be billed multiple units, but you need to meet or exceed those 15-minute time thresholds. I also want to call out, because these are home visits, this does not include travel time to the patient's home. That is not considered a qualifying activity. All right, finally, before I check in with Ashley for any questions, we are going to talk about documentation requirements for home care. So documentation for home services, it's not really that different from documenting any other services. These are E&M services that are provided in the home, so really not documenting different than E&M services that are provided in the office. But your documentation does need to clearly support what happened during the encounter and what you did for the patient. So first and foremost, which is the basis for reimbursement for any services, is why the services were medically necessary and why the patient needed them as it relates to their plan of care. As I mentioned earlier with incident 2, we need to know who provided the services. So was that the doctor? Was that the nurse practitioner? Was that Nurse Jackie? We just need to know who's providing those. The documentation also has to include what the plan of care is for this patient. This could include any interventions that they have coming up, they have planned or that you're considering, what needs to happen for that patient. It also could include goals for the patient's care. How do we know that things are working, or how do we know when it's time to adjust that plan of care? As I mentioned with homebound criteria, if your patient is homebound, not all home services require that, but again, with that incident 2, it does require them to meet that criteria. So if your services do require the patient to be homebound, make sure the documentation is supporting how they meet CMS's definition of homebound, meaning they're meeting criteria 1, which is needing that supportive device or needing another person to leave the home, or that they have a medical condition that's contraindicated, or criteria 2 that we talked about. So like all documentation, your documentation does need to support that level of service that's been billed. And as I've said, this is true regardless of the type of service that you're billing. We're not looking for any particular statements. Again, we talked about making sure that we're establishing that homebound criteria and who's providing those services. But outside of that, documenting for home services is pretty much like documenting other services. So if you're using medical decision making, it does need to include The problem, the data, and risk. The elements that are included in that are going to be that evaluation and exam, their history, the assessment, which is that exam, their care plan, and then what services are being provided. If you are selecting your level of service based off of time, you need to account for the time that was spent with the patient. Best practice is to not utilize a range. So something like I spend 15 to 30 minutes with the patient, that is not your best practice. We're not asking providers to stopwatch themselves, but it shouldn't be a range or a general statement. It should be I spent 20 minutes with the patient, or approximately 20 minutes with the patient. Just not that range, because that range can actually impact which code's billed. And this documentation, as with all documentation, is the provider's proof of thought. If it's not documented, our reviewers don't know that it happened. We're certainly not asking providers to write a novel. We don't necessarily need, word by word of what happened, but we need it to be clear why the level of service that's being billed is appropriate. So before I check in with Ashley for questions, I did want to point out the resources that I have included. I included the benefit policy manual and the claims policy processing manual. We went out to both of those today. I've included a couple of additional sections with that claims processing manual. That evaluation and management services guide is out there. I've also included a resource that we have on E&M documentation to help you along your way. And of course, in a couple of places, I did give you a link to that telehealth FAQ. It's not just specific to home services, but it is something that I believe everybody is going to find helpful, especially with those flexibilities expiring at the end of September. All right, so before I check in with Ashley, I do have one pre-submitted question that was received, and it was asking about the appropriate billing for home INR monitoring. And they're saying the scenario is when the patient calls in their results weekly. Question is, which is the correct place of service and which code would be used? So this is a great question. They're monitoring at home and they're reporting those services, but they're just reporting those services. So that's actually going to be billed with the place of service 11. That's not actually a home service. The service itself, what the provider's doing with that, is not happening in the home. So they use place of service, and the code that's used for that is G0249. All right. The other questions that we received pre-submitted were incorporated into today's material, so I am going to check in with Ashley to see if we have any questions in the chat.
Leanne, we just had one question come in. This question says, for documenting why services were performed, would this be satisfied by documenting the condition or conditions which were supported in the HPI and/or exam, or is there more that should be added?
That's a great question. Certainly the diagnosis is going to support it, but it does, based on diagnosis, everybody's treatment needs are going to be different. Their plan of care could be different specific to the patient. So while those diagnosis codes do support why services were performed, we do need additional information as to why the services were performed for this specific patient.
All right, and it does not look like we've received any additional questions.
All right, well, this is certainly not your last opportunity to ask your questions. I will be taking questions for the next 7 days, and Ashley is going to put some information in the chat for how you can get those to us. What you'll do is you'll send out any follow-up questions to our education mailbox, which is that wps.jha.education@wpsic. And in the subject line includes something about home services. The title of today's event is that E&M training camp, home services part 1 of 2 in the subject line, and that's just going to let those that monitor that mailbox know these questions need to get to Ashley and myself so that we can get answers to you. So please feel free to send those in. Anything specific to a claims denial or a claim in process, those do still need to go to customer service, but otherwise any general policy questions about home services, send those our way and we will get you a response for that. So in the next few minutes, you are going to get an email thanking you for attending. There's a couple of things. Don't delete that without reading it. This email contains your certificate of achievement if you were attending today for continuing education credits. While we don't issue those credits, we do offer contact hours that can be submitted to your accreditation body or certification body. So inside that, what you're going to see at the bottom of the email is going to be the title of today's session, and then the contact hours. You submit that email and your accreditation body, your certification body will credit those towards your continuing education credits. You're also going to have the ability to take our survey. Again, I would encourage you to provide us with some feedback. Your opinion, your feedback helps us steer our educational offerings to make sure that we're meeting your needs. And I know nowadays we seem to be asked for a survey at every turn, but we really do look at all of this and take this feedback to heart when we're planning our educational events for you. So tell us what we did good, well, tell us what we could do better, tell us what you'd like to see in the future. We want to see it all. So the way you can take that is a couple of ways. One, Ashley just put a link in the chat. Click on that, it'll take you to the CMS Qualtrics survey. The other is you're seeing this external site image on your slide. This is a pop-up that you'll get as you leave today's session. This is not spam, it's not malicious, it's not taking you anywhere dangerous. It's simply letting you know that you're leaving our webinar software and going into the Qualtrics survey software. So that is just another way for you to access that. Your preference, but both are available. I want to thank everybody for attending. That ends our session today. I do want to encourage you, if you have not already registered for Ashley's event on denials and rejections and how to avoid them, and that interactive opportunity to apply your knowledge from today, I encourage you to take a look at that and consider registering for that. It is offered at the same time as this session today, so 10 a.m. Central, 11 a.m. Eastern Time, if you're interested. So on behalf of myself, Ashley, and everyone on the WPS Provider Outreach and Education team, I'd like to sincerely thank you for taking the time to attend today. I know everybody's super busy and it can be hard to carve out this time. So I hope you found this information useful, and we look forward to hearing from you. With that, I hope you all have a great rest of your week and continue to be well. You may now disconnect.